European School of Oncology. The e-session will start soon. Thank you for your patience. Today's e-session will start at 6:15 p.m. Thanks for waiting. European School of Oncology. The e-session will start soon. Thank you for your patience.
Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 587. Today's session is Soft Tissue Tumors in Childhood. Please note that this activity is CME accredited. At the end of the presentation, go back to the ESO website to complete the evaluation form and the CME multiple choice test. Mastermind competitors will be prompted to start the quiz after having completed the evaluation. As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the bottom of the page. Questions will be received by Dr. Andisha Tarbuski of the St. Anna's Children's Hospital, Vienna, Austria, who will discuss them with Dr. Andrea Ferrari of the National Cancer Institute, Erx Foundation, Milan, Italy. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Ferrari. Doctor, your line is now open.
Hello everybody, good evening. Did you see my screen?
Not yet, Andrea, not yet.
Oh, say pause. Let's understand what is the problem. We tried many times and now we have some problems.
You have to, yes, now you have to get to the presentation mode.
Now it's
Yes.
okay?
Yeah, it's great.
Okay, perfect. So, it is difficult to talk about soft tissue sarcoma in childhood in 30 minutes, especially because soft tissue sarcoma are a very large group of different tumors with different biology, different clinical course, maybe different treatment. And so I will try to do my best to focus on some specific aspects coming from my personal experience, from study where I was directly involved when possible. So this is the definition of soft tissue sarcoma, a very heterogeneous group of more than 50 different histological subtypes, classifying on a histogenic basis according to the adult tumor they resembles. They account approximately for 4–5% of childhood cancers. And you can see here that around half of the cases are rhabdomyosarcoma, and half of the cases are the so-called non-rhabdomyosarcoma soft tissue sarcoma. And here on the right part of the slide, you can see the specific characteristic of rhabdomyosarcoma and non-rhabdos. Rhabdomyosarcoma is a typical embryonal tumor of childhood. It is often and it is always an high-grade tumor, so high grade of malignancies, local invasiveness, marked propensity to metastasize, to the point that all rhabdomyosarcoma patients should be assumed to have micrometastasis at diagnosis. And so all the patients with rhabdomyosarcoma should be treated with chemotherapy, regardless of the stage of the disease. But the good news is that these tumors are generally responsive to chemotherapy, 90% of response to chemotherapy and to radiotherapy. And in green, you can see here non-rhabdos that are completely different tumors. There are rare tumors. Most of these tumors are typically found in adults. There are a long list of very extremely heterogeneous tumors, and generally they are considered to be scarcely responsive to chemotherapy. And this idea is to say that adult medical oncologists and pediatric oncologists do mean very different things when they talk about soft tissue sarcoma. You can see in this slide that the histotypes occurring in children in green are very different from the histotypes occurring in adolescent and young adults, and very different to those occurring in adults. In adults, we have liposarcoma, leiomyosarcoma. In children, we have rhabdomyosarcoma. In adolescent and young adults, we have, for example, synovial sarcoma. So it's important to understand that sometimes the experience, but also the attitude of adult medical oncology and pediatric oncology to this tumor are different from the reason. And the second figures tell us that the patient outcome is different according to the patient age, with survival rates drop when age increasing. You can see here the outcome of pediatric patients is often better than the outcome of adult patients. I want to start with my talk with rhabdomyosarcoma. This slide is just to show you a quite a recent review with a lot of discussion on the biology of the tumor, clinical aspect, and treatment. And so you can find this on PubMed, for example. And these are the four main key aspect of the treatment, the management of rhabdomyosarcoma. First, the centralization of care in very specialized centers and the wide cooperation on national and international level that is strictly linked to the concept of a high rate of inclusion in cooperative multi-institutional clinical trials in order to collect a large number of the cases. This figure tells you that we are talking about a rare disease, and you can see here just an example. In red, German protocols, in green, Italian protocols, in blue, French and UK protocols, and you can see that this protocol merged in 2005 in the so-called EPSG, we will talk later, and in yellow the North American protocol, and you can see the number of the patients enrolled in randomized clinical trials, starting from the 17 up to date. It is just to say that we are talking again, rhabdomyosarcoma, very rare tumor. More than 10,000 patients were treated within randomized clinical trials. So a huge number that characterized the attitude of pediatric oncology in general, and in particular of the expert on soft tissue sarcoma, to work together and to include patients in randomized clinical trials. The only way to really understand how to better treat our patients with the disease. And then the concept of the high rate of inclusion in clinical trials. This is a more recent study we published within the EPSG. You can see just this number. It is the observed expected patient. That means the number of patients really enrolled in the EPSG trials and the number of patients expected to be seen according to the incidence rate. And if we talk about rhabdomyosarcoma, and if we talk about patients from 0 to 14 years old, 77% of the patients occurring in Europe were enrolled in clinical trials. That's an incredible number of patients. And the other point is the concept of using a risk-adapted treatment strategy. That means the idea to identify different prognosis factors, different variables, able to stratify the patients in order to give more intensive treatment for the patients with more risk of relapse, while to try to give less intensive therapy to avoiding over-treatment and containing side effects with the patients with more favorable disease. And you can see here on the right part of the slide the different prognosis factors. And so factor related to the patient, the age of the patient. We know that patients less than 10 years old have a better outcome as compared to the patients more than 10 years old. Factor related to tumor, so the histology, we know that the embryonal tumor have a better outcome as compared to alveolar tumor. The size of the tumor, this is clear. The site of the tumor, because you can see here different tumor site, paratesticular site, parameningeal site, a tumor arising in the abdomen, a blood and prostate tumor, a tumor in the limbs, and the different sites have a different prognosis. Paratesticular tumor or tumor of the orbit or tumor of the vagina have a better outcome as compared to tumor of the limbs, for example. And then, of course, we have some factor that can be related to the treatment. That means the modality used in the treatment. If we treat our patient the best way, of course, the outcome may be better, and the response to therapy. And according to these different variables, we were able, over the years, to identify a multidisciplinary approach and a multi-variable certification. And you can see here that that is the approach we used in the last EPSG protocol. We will come back later on this point. And you can see that we are able to identify 8 different risk groups from A to H, according to the histology, the stage of the disease, the nodal status, the tumor size, the patient age. And you can see that the outcome of the patient, the predicted outcome of the patient, changes according to the different risk groups. And so we will see how we treat these patients and how we treat these patients. And this is just to remember you that you can send the question, and if you have some burning question on this point of rhabdomyosarcoma, please, you can interrupt me without any problem. And so, again, we are talking about this. This is the EPSG, just to show you what are the countries involved in this a very large group that include more than 15 countries and more than 100 centers enrolling patients. And as I told you, patients with a favorable risk group, so the so-called group A, were treated just with a very mild chemotherapy, the combination of vincristine and actinomycin, so no alkylating agents, very short treatment, and the outcome was excellent, with probably really less probability to have late sequelae in the future. And then we have the standard treatment, the IVA treatment. We'll talk later about this for the patient with the outcome between 80, 85, and 90%. And I want to stay on this group of patients, the patients so-called to be at high risk, the patient for which the protocol tried to intensify the treatment with 2 randomized studies to try to improve the survival. And these are the 2 randomized studies we tried to discuss in the 2005 protocols. First randomization, the so-called anthracycline questions. The question was if a patient with rhabdomyosarcoma may benefit from a greater doxorubicin dose intensity in the initial part of the treatment. And you can see here the IVA. The IVA is the standard treatment that we use in Europe for more than 30, 40 years. That is a combination of ifosfamide, vincristine, and actinomycin given for 9 courses. And on the other side of the Atlantic, the treatment was very similar. Instead of the IVA, we have the VAC that is exactly the same, with cyclophosphamide used instead of ifosfamide. Well, in the protocol, we try to randomize patients to receive IVA versus IVADO. That means the same regimen with addition of doxorubicin. We know that doxorubicin is effective in rhabdomyosarcoma, but we did not know if adding doxorubicin to the IVA regimen may really increase the outcome of our patients. And after the conclusion of the 9 courses of chemotherapy, we have the second randomization, a very novel strategy. The idea was to stop the treatment, that was what we did before 2005, or to try to give a maintenance therapy after completing the conventional chemotherapy. So a treatment that give regular and frequent low dose of drug with the idea to have a metronomic therapy to try to have an anti-angiogenic effect. And it was based on 2 consecutive studies we developed in Milano, in Italy, with the use of vinorelbine and the use of vinorelbine combined with low dose oral cyclophosphamide. And this is in some way the idea to have a first randomization, IVA versus IVADO, and the second randomization, stop therapy versus maintenance question. And so, the results of our 2005 protocols, the first randomization, the addition of doxorubicin to IVA. You can see here the response rate, IVADO versus IVA, and you can see here the 2 curves that were exactly the same. And so the first randomization say that doxorubicin does not add any significant anti-rhabdomyosarcoma activity to the standard multi-drug regimen, the so-called IVA therapy. And what happened with the second randomization, stop therapy versus maintenance therapy? You can see the number of patients enrolled, 186 versus 185. And you can see here the curves. This was an incredible success. The event-free survival, but in particular the overall survival of the patients increased in the arm receiving the maintenance therapy from 73.7% to 86.5%. So you can see that the peak was statistically significant. So this study demonstrated that adding maintenance treatment with vinorelbine and low-dose oral cyclophosphamide to patients with high-risk rhabdomyosarcoma in complete remission after the first 9 courses of treatment was first well tolerated and second improved survival. This was the first randomized study to demonstrate a survival benefit related to an experimental chemotherapy regimen in rhabdomyosarcoma over the past 3 decades. And this is just an example, a list of the different randomized studies performed by the Children Oncology Group, the North American group, that used to have a long list of historical studies to be compared to VAC. VAC was the standard treatment, and you can see VAC versus VAC plus doxorubicin and cisplatin. VAC versus VAC plus doxorubicin, cisplatin, and etoposide, or VAC plus IVA, or VAC plus VA, and then the introducing of topotecan, and then the introducing of irinotecan. And all this study was exactly the same. No any of these alternative regimen increase the outcome of the patient as compared to those receiving VAC. And so the result of our EPSG maintenance trials was really considered in home run for rhabdomyosarcoma after 30 years. And you can see also how the mass media was really surprised for these results. And though in some way we can say the maintenance chemotherapy in rhabdomyosarcoma became the new standard of care. This was the standard of care before 2005 in Europe, 9 courses of IVA, and now this is the standard of care, IVA plus 6 months of maintenance therapy. And then the same for North America. The North American friends closed the study, the ongoing study, amended then to introduce the concept of maintenance therapy also in their treatment. It remains to be clarified, of course, if these great results was related to the effectiveness of the drug involved, in particular vinorelbine. Vinorelbine was the new drug we added the maintenance therapy. Or maybe it could be just simply the prolongation of the chemotherapy cured a large number of patients as compared to the patient that completed the treatment. So just related to the increase of the duration of the treatment, or both. And now we are trying to understand what is the real reason for these great results. And for example, this is our idea in our Milan group. We try to use vinorelbine, that is our drug. We try to really demonstrate if it is vinorelbine to be the real effective part of the maintenance therapy. The idea is to use vinorelbine not only in the maintenance, but to use in the advanced part of the treatment. And so this is a concept that tries to introduce vinorelbine in the middle of the different IVA courses. And so on some way to use the new drug, vinorelbine, on the other way to give a more intensification of the treatment, dose density, to give effective treatment in a period shorter than the usual 3 interval weeks. On the other side, we try to understand if it is a problem of the prolongation of the therapy. And so in the future protocol, this is just a schema, you don't have to understand about this, that in the future protocol in Europe, we try to develop a randomization between 6 months of maintenance therapy versus 12 months in patients with localized high-risk disease, while in patients with metastatic disease, we try to randomize patients between 12 months versus 2 years of maintenance therapy. So this is the direction we are going after the results of the maintenance therapy. So again, if you have some question, it's better to have some question now if you want to do some question of rhabdomyosarcoma and the EPSG protocols. So no problem.
Andrea, may I ask you one question?
Yes, of course.
Concerning your doxorubicin randomization, was there any difference between alveolar and embryonal rhabdomyosarcoma by adding doxorubicin or not?
No, not, because we try to stratify the patient also according to the response of the treatment, because sometimes happen that we treat in the same basket of rhabdomyosarcoma 2 tumors that are probably different from a biological point of view. Patient alveolar rhabdomyosarcoma, or as we call today, fusion positive rhabdomyosarcoma, has a different biology as compared to patient with embryonal or fusion negative rhabdomyosarcoma. So it's possible that a specific treatment, a given treatment, may be effective in alveolar and not in embryonal rhabdomyosarcoma. So the question is correct, but the results of the negative result of doxorubicin was exactly the same for embryonal or for alveolar rhabdomyosarcoma.
Thank you.
Okay. Other question or comment? Okay.
Not from the audience, no.
Okay. While waiting, I go forward. And I have shown you some very good results we discussed the curves around 75%, 80%, 65%, but we were talking about patients with localized disease. The situation for rhabdomyosarcoma patient is completely different if we talk about patient with metastatic disease or patient that relapsed. So patient with metastatic disease or relapsing tumor remain patient with a poor outcome. And so you can see here a couple of cures that suggest that we absolutely need to find novel treatment to increase the outcome of these patients. And so what are the strategy we developed in the last years? This is the strategy used by the Children Oncology Group for metastatic disease, the concept of the dose compression to give full doses of chemotherapy administered not every 3 weeks, but every 1 or 2 weeks. So as I showed you before for the VIVA regimen, the intensification of the treatment to try to increase the dose density. This trial demonstrates that this very intensive treatment is feasible and it can be effective in some particular specific subset of the patient, not for all metastatic patients. And this is to show that alternative ideas are ongoing, use the concept of the dose compression. Again, the VIVA regimen that gives vinorelbine in the middle of the different IVA courses. Well, this is another strategy, again, an Italian study we recently published, to use irinotecan, that is an effective drug. We use irinotecan in Europe as a first line after relapse. And the idea is to use irinotecan in front line in patients with high-risk disease. And you can see the concept to give IVA at day 1 and 2. And then you will have after 3 weeks the second IVA courses, and irinotecan is given during the second week of the treatment. The result of these pilot studies are very promising, but of course we need to try to understand in a more large study if the IRIVA regimen may really increase the outcome of our patients. And the next EPSG protocol will use the IRIVA regimen as part of their treatment strategy. Then, of course, the concept to try to have a new drug that can be added to the classic IVA or VAC regimen. And this, for example, is a study we developed with bevacizumab it was the so-called burning protocols, metastatic patient with rhabdomyosarcoma and also with some specific non-rhabdomyosarcoma, soft tissue sarcoma. The patient received the IVADO treatment, the one we consider our standard in metastatic patients in Europe. Half of the patient received IVADO, half of the patient received IVADO plus bevacizumab, and unfortunately, the outcome was exactly the same. To say that bevacizumab was a good idea, was to try to have a target therapy, an anti-VEGF therapy for our patients, the outcome did not increase. This is another concept to have a new chemotherapy drug, temozolomide. This is a treatment we use for a patient at relapse in Europe. Vincristine and irinotecan, as I told you before, was our standard therapy at relapse. We try to randomize patients to receiving vincristine and irinotecan with or without temozolomide, while the patient receiving VIT regimen, vincristine, irinotecan, and temozolomide, have a clearly better outcome as compared to the patient receiving VIA only. And so the idea is that today our standard treatment at relapse is VIT and not only VI. And then, of course, the idea to look to target therapy, to new agent, novel agent, and these are the result, the treatment schema in the North American group with mTOR inhibitor. And the concept is that mTOR inhibitor may be seen as a new drug that can in some way increase the outcome of the patients. Looking to biology is of fundamental importance for many, many reasons. Of course, for diagnosis, to try to have diagnostic biomarkers. Of course, to have prognostic biomarker to identify according to the different biology of the tumor, high risk and low risk patient, but in particular to try to identify target and clinically relevant novel agent to have to combine them in the future with the standard chemotherapy. It's just a figure to show the possible pathway, and this is a list of the possible target therapy we can use. One of just to show you one of the targets we are focusing in our group is the potential rule of ribographin. Again, if you have some question on rhabdomyosarcoma, exactly, because then we will go to non-rhabdo. Okay, perfect.
From a colleague. The first question is dealing with the importance of age in metastatic rhabdomyosarcoma, something we know very well, but you may comment.
Yes, of course, we say we don't have time for talking about everything, but when I show you the very poor curve of metastatic patients, around 20% of overall survival, there are also some curves that demonstrate that not all metastatic patients are the same. We know that the clinical factor used to be important in patients with localized disease, may be important also in patients with metastatic disease. And so age is one of these factors. If you have a metastatic patient with age less than 10, with only metastasis at the lung, for example, and with embryonal rhabdomyosarcoma, we know that the overall survival may be around 45–50%, quite close to the outcome observed in patients with localized disease. While, on the contrary, if we have a patient of 18 years old with alveolar rhabdomyosarcoma, with metastasis not only in the lung but also in the bone, for example, in the bone marrow, the outcome is closer to zero. So age is one of the factors we can use also to stratify patients in metastatic setting.
And the second question is, would you consider temozolomide as a drug which could make the tumor more sensitive to radiotherapy?
I believe yes, not totally sure. I think that it can be used also to have a radiosensitization of the tumors.
Thank you.
If you have other comment on rhabdo, otherwise I will pass to the second part of my talk, talking about non-rhabdos. Okay.
Yes, thank you. Now we have 15 minutes left.
Yeah. Okay. I told you before, non-rhabdo are rare tumor. Most of the tumor entities typically found in adults, extremely heterogeneous, scarcely sensitive to chemotherapy. This is just to show that the heterogeneity of the tumor may be related to the different histology, cinemasarcoma, liposarcoma, leiomyosarcoma, epitheliosarcoma, and so on, to the different biology, because we know today that the specific molecular finding on the different histotype we can have. And you can see this table, you can see them, the table with more time after the conclusion of the presentation, but we know the different characteristics of the different tumor and different biology. The different clinical experts, again, tumor arising in the limbs or in the abdomen or in the lung, and also different outcome, because under the umbrella of non-rhabdo, under this definition, we have patient with this outcome and patient with this completely different outcome. And I like to remember that in the past, non-rhabdo were considered quite orphan diseases. We have very few trials, just a couple of trials from North America, very few patients enrolled. And the largest reported series of pediatric non-rhabdo before 2005 were two single institutional experiences, the one from St. Jude and the other one from our centers. And the major problem was that, at least in Europe, we often treat non-rhabdo patients according to the rhabdomyosarcoma protocols, and the different tumor entities were put together in the different studies, in the different analyses. For example, including together in the same group truly malignant tumors or soft tissue with intermediate malignancy. And the situation changed as in 2005, because in the North American group and the EPSG group, we started quite in the same times to trials completely dedicated to non-rhabdo. And these two trials were very, very similar in terms of the rational patient stratification, treatment programs, and the studies were very recently published and represent the benchmark for this tumor and defining a risk-adapted treatment standard of care. And now we can also, the second generation of North American trial, that it was the first trial in cooperation with the adults that can use also target therapy. And this is the EPSG trials. As I said, I will try to talk about our experience. The EPSG 2005 trial dedicated to non-rhabdo included 2 prospective non-randomized historic controlled trials, one on synovial and the other on the so-called adult types of tissue sarcoma. And we gave a very precise definition of adult types of tissue sarcoma to separate this tumor from this tumor, the so-called other histotypes, for which we provided just guideline. And you can see here infantile fibrosarcoma, excellent outcome. Desmoplastic small cell tumors, a completely different outcome, but also a completely different biology and clinical history as compared to other histotypes, and then other tumor like malignant ectomesenchyma, epithelial hemangioma, or tumor like desmotype fibromatosis and inflammatory lymphoblastic tumors or rhabdoid tumor, and so on. And in the last years, the EPSG published the different series for the different histotypes to try to understand that it's better to analyze histotype by histotypes, and you can find this in literature, and this just to show how the outcome and the response to therapy, for example, was completely different in these different tumor types. And I want to use my residual time to talk about this last publication, 2021, that was in some way the analysis of the whole non-rhabdo EPSG series. And this is the diagram of the number of patients we enrolled, the number of patients excluded, because as I review, they have a different histology. The number of patients excluded because they have the so-called other category. You can see, as I said, infantile fibrosarcoma, desmoid tumors, rhabdoid tumors, and so on. Patient with missing data, and then the patient we analyze. 569 patients, some were synovial some were adult type non-rhabdo. Here you can see the different list of the different histotypes included, to say that for some histotypes, the number of the patients was really very small, 19 sarcoma, 30 angiosarcoma, 17 clear cell sarcoma, and so on. And we differentiate the patient according to the treatment category. This is the treatment category we have. According to the clinical variable that was the IRS group, that means the resectability of the tumor, group 1, 2, and 3, according if the patient were resectable or not, the diagnosis. The tumor size, less or more than 5 centimeters, the tumor grade, and for synovial sarcoma, also the tumor site, because we know that synovial sarcoma may arise in the axial site, that may have a completely different outcome compared to tumor of the limb. And according to this category, we have patient treated with surgery alone, patient treated with adjuvant radiotherapy alone, patient that receive adjuvant chemotherapy after initial resection, and patient with unresected tumor that receive neoadjuvant chemotherapy. And this is just to briefly show the general outcome of our series and the outcome according to the different risk group. And these are, in some way, the conclusion of our trials. The study demonstrated that adjuvant chemotherapy and radiotherapy can be safely omitted in low-risk non-rhabdo. You can see here the blue curves, excellent outcome with surgery only. The chance to investigate in the role of adjuvant chemotherapy in patients resected at diagnosis was very limited because of the limited number of the sample. Our study, however, confirmed that despite the global good prognosis of resected non-rhabdo, patients with the high-grade and large tumor remain at risk of metastatic spread. And then patients with resected cases sorry, 1 second. Sorry, we demonstrated that the neoadjuvant enforcement absorbance in chemotherapy improved the resectability rate compared to previous study, and we had better results than compared to the past. So I will be a few minutes if I'm able to survive. So again, these are a list of the challenges for non-rhabdo that we have to phase for the future, very briefly, to find a way to improve the outcome for patients with high risk, to better use the standard therapy we have, the combination of enforcement and doxorubicin. The idea is to have a better patient selection according to the prognostic variable in order to give chemotherapy to the patient at major risk of metastatic failure. According to the histology, patients that have more probability to respond to chemotherapy, alveolar sarcoma, clear cell sarcoma will rarely respond to chemotherapy, while synovial sarcoma have a better response to chemotherapy, but also today, according to tumor biology, I understand that, for example, the genomic index can be a predictive variable that can in some way suggest if the patient may respond or not to chemotherapy. As I said, the idea to study NORAB together, or single isotype by single isotype, but it remains a problem because we have very few cases for some specific isotypes. We are all patients with adolescent and young adults. This is exactly the same study I showed you before for rhabdomyosarcoma, but if we talk about non-rhabdo, if we talk about adolescents, you can see here that only less than 20% of the patients occurring in Europe with non-rhabdo in the adolescent group were enrolled in our protocols. So we need to find a way to enroll AYA in our group. And this means better cooperation with the adult sarcoma community, pool resources together, increase international cooperation, developing biological study, because we need the new biomarkers to improve risk stratification, but also to novel therapy. And this is just to show you what will be the next EPSG protocol for the future, a protocol that is called My Kids, that is mainly focusing on the biology of the tumor more than on the treatment. The concept of the asset to new drug, because there are a lot of new drugs coming from the world of adult sarcoma, but we know also that the asset to new drug for children and adolescents may be more difficult as compared to adults, and the impact of target agents in the pediatric population is not parallel the progress in adult patients. We can have many barriers, but the best way is to try to better cooperate with adult experts. And also, if we will be able to have target therapy, we need to understand how to use this target therapy. Just a few examples. We know, for example, that in infantile fibrosarcoma, together the inhibitor of NTRK may have a wonderful efficacy in this tumor, but we know also that this tumor, infantile fibrosarcoma, has an excellent outcome. More than 95% of the patients survive at 5 years with just very much vincristine and actinomycin chemotherapy. So here we have a drug, but we don't know if we want to use instead of chemotherapy or only after relapse. Or the same in inflammatory microvascular tumor, the role of ALK inhibitor, for example, or for example, the use of tyrosine kinase inhibitor in the treatment of pediatric dermatitis tumor, tumor of intermediate malignancies that have very good outcome without target therapy. How we can use target therapy for this tumor. So many challenges. And I suppose this was my slide. A short and clear take-home message. What I can say, a lot of things, a lot of different tumors, a lot of trials. My message may be that only with the cooperative multi-institutional work together, we can really improve the outcome of the patients, and only with real expert on this disease, we can really try to change the outcome of these heterogeneous, difficult patients. Thank you, and sorry for the time I spent with the
Thank you, Andrea, for this great insight into rhabdomyosarcoma and non-rhabdomyosarcoma soft tissue tumors. I think we have time for 2 or 3 questions. One question from the audience is, what is your experience with the treatment of triton tumors? I think it's a subtype of malignant peripheral nerve tumors. Could you comment on that?
Yes, it's a difficult question, because what is triton tumor? It's difficult to say. Probably we now consider triton tumor a tumor with that is part of MPNST, that means malignant peripheral nerve tissue tumor. It's a tumor that responds not so well to chemotherapy, for example, but also with a rhabdomyosarcoma differentiation. what we think today is to treat triton tumor as rhabdomyosarcoma because it's the most aggressive part and probably the part that may have more probability to respond to chemotherapy. I'm not totally sure that is really the solution for the question. Today, we treat triton tumor as rhabdos, but we know that we need a new drug and new strategy.
Thank you. Perhaps I can ask the next question. Due to the lack of time, you could not comment on the role of surgery. What I'm personally very much interested in is what is your opinion on mutilating operations after 9 courses of chemotherapy if there is a significant residual tumor before starting oral continuation therapy?
Yeah, we didn't have time. Surgery is a critical part of the treatment for rhabdo and for non-rhabdo, more than for non-rhabdo, if I can say. I believe that today, in the new era of the treatment for rhabdomyosarcoma, that remains a tumor that can receive different level of effective chemotherapy, that can receive radiotherapy, it is difficult to propose mutilating surgery in front line. A different issue at relapse, but to be honest, after the 9 courses of chemotherapy, thinking to mutilating surgery is probably too much. The only situation may be when you have very small children that cannot receive radiotherapy. I don't know, I can imagine a child of 1 year old with a very huge rhabdomyosarcoma of the limb that do not respond to chemotherapy. Otherwise, I would leave mutilating surgery, for example, at relapse, not as first part of the treatment. You're mute, Anish?
Sorry, I was thinking on tumors of the bladder. When you have, for example, really an embryonal rhabdomyosarcoma with a significant residual in the bladder after chemotherapy and radiation.
Sorry, I went directly to the concept of amputation and not mutilating in the term of, yes, bladder and prostate tumor is a big problem. And I believe that there are more situations when this kind of surgery may be acceptable. Again, I'm thinking to small children, 2 years old, 3 years old.
Yeah.
We know that giving radiotherapy may be probably cause of severe future sequelae more than a mutilating surgery of the bladder. And we know that today, in the future for the child, when he grow up, we can have a good way to reconstruct the bladder and so on. So in this case, mutilating surgery may be, of course, an option that you can consider.
Yeah.
Yes.
Thank you, Andrea. I think if there are no more questions left in the audience, I would really like to thank you for your time. I know that you're very, very busy with different things at your institution, but it was also a pleasure for me personally to listen to your talk. And yes,
I was able to raise the hand, so this is the best thing for me. Sorry again.
So thanks a lot. And I wish all a very nice evening and hope to see people from the audience again at the next session, which is advertised here now on the next slide. But the whole program of the ESO Pediatric Oncology pathway is also visible on the website of ESO. So have a nice evening. Bye-bye. Ciao.
Thank you. Thank you. Goodbye to everybody.
Ciao, Andrea.
Ciao.
Thank you, Dr. Ferrari, and thank you, Dr. Atabaski. Ladies and gentlemen, the session has now concluded. If interested in CME accreditation, participants should fill in the evaluation form and pass the CME multiple choice test. To enter the CME section of the site, please close this window and go back to the ESO website. If you are a mastermind competitor, you will enter the quiz after the evaluation. The next ESO session will take place on the 27th of September at the same time. And Dr. Momcilo Jankovic of the San Gerardo Hospital, Monza, Italy, will discuss with Professor Federico Pelagata of the Milan University, Milan, Italy, the following topic: oncology and end of life. Thank you for participating and have a pleasant evening, day or night. Goodbye.